Hi and welcome to this webinar. My name's Michelle Robbins. I'm a credentialed diabetes educator for the last 30 years and a nurse practitioner. And today's webinar is looking at diabetes management and severe mental health. But I just want to set the scene in looking at mental health nationally. And the Australian Bureau of Statistics back in 2018 found that 1 in 5 Australians, or nearly 5 million Australians, have a mental health or behavioural condition, and that's increased substantially over the last few years. That 13% had an anxiety-related condition, which has again increased slightly in the last decade, and that 1 in 10 people have depression or feelings of depression, and again that's increased. Post-COVID, one would expect that those numbers would be much higher. Younger people have higher rates of mental or behavioural or anxiety-related conditions, but older people have higher rates of depression. But females across all age groups have higher rates of all conditions. And the lower someone's socioeconomic level is, the higher these rates are, again across all types of mental health conditions. So we know that there is an absolute link between antipsychotic medicines and the metabolic syndrome. And this often is parallel to an unhealthy lifestyle that many people with severe mental illness have, and that could include the sorts of things that they're eating or drinking, a lack of physical activity, higher rates of smoking. The metabolic syndrome, or the awesome foursome as we often call it, is associated around central obesity, high blood lipids, high blood pressure, and higher than normal blood glucose levels. And we know that people with schizophrenia in particular have very, very high rates of developing type 2 diabetes. So this is just an illustration, a figure where when we look at a number of psychiatric disorders and we look at the behavioural mechanisms around increasing the risk of type 2 diabetes, there is the lifestyle issues around the eating habits, physical inactivity, alcohol, substance abuse, sleeping disturbances, because we know that unhealthy sleep will increase insulin resistance and increase the risk of type 2 diabetes. Smoking absolutely increases the risk of type 2 diabetes. And then the issues around attending medical examinations, getting routine checkups, and medication adherence. So again, people who might be already prescribed medicines for blood pressure or cholesterol lowering may not actually be taking those medications. But then there's a lot of biological mechanisms around psychiatric disorders, but also then that's enhanced by some of the medications that we then use to manage these conditions. And that's really what the focus of this webinar will be looking at. So when we look at antipsychotics, there are two different classes, the conventional and the atypical, and both alleviate the symptoms of psychosis and mental health conditions, but it's the atypical antipsychotics, the newer class, that actually can treat a much broader range of conditions, and this is much more widely used than the older or conventional class. However, it comes at a cost, and some of these agents are known to increase blood glucose levels and increase then the risk of type 2 diabetes. Or if someone already has type 2 diabetes, it's going to actually exacerbate or worsen their diabetes control. We're not really sure how they work on the brain, but we know that the atypical antipsychotics have a significant effect on appetite and a substantial effect then on weight gain. We know that they target the hypothalamus around appetite, but they also can target the liver, which is a storage of glucose, and maybe also contribute towards things like a fatty liver. They target beta cells that release insulin, They also can target the storage of fat in adipose tissue and how effective insulin is in moving glucose into skeletal muscle. Atypical antipsychotics can affect a number of systems in the body. So, as I said before, they can affect the way insulin moves glucose into skeletal muscle and therefore create a degree of insulin resistance. It can affect the way liver stores and then releases glucose, particularly at times where it's not required. It can affect appetite in the hypothalamus and therefore increase appetite. It can change the way beta cells are working in terms of how much insulin is being released and maybe affecting the deterioration of those beta cells, as well as lipid accumulation in fat cells, which again creates insulin resistance, particularly around central obesity. So, as far back as 2003, the FDA in the US actually listed atypical antipsychotics as being an increased risk of developing type 2 diabetes. And it reminded that, clinicians that these listed mental health conditions and behavioural issues where atypical antipsychotics could be used. So not just in schizophrenia, but for a wide variety of conditions could increase the risk of type 2 diabetes. So for people with pre-existing mental health conditions and type 2 diabetes, worldwide, we think that type 2 diabetes affects 6 to 9% of the population. In the US, it's slightly higher, and it is higher in Australia. But we find much, much higher rates of type 2 diabetes in people with psychiatric disorders. So higher rates of type 2 diabetes for people with a sleep disorder. 1 in 5 people with a binge eating disorder will develop type 2 diabetes. Higher rates in substance use disorder, anxiety, bipolar, and psychosis. I've listed here a number of adverse outcomes from widely used atypical antipsychotics. And you can see that clozapam and lorazepam have substantial improvements in terms of cognition, but they both come with substantial weight gain, substantial risk of type 2 diabetes, high blood fats, whereas I've listed other agents that have less weight gain and less risk of having type 2 diabetes. So the Australian Diabetes Society, so that's the endocrinologists and scientists, released a position statement around prevention and management of type 2 diabetes within the context of psychotic conditions, and that it was really about being aware of baseline measurements that should be done and repeated at regular intervals. So we need to be looking at people's weight and waist circumference, their BMI. We need to be measuring their blood pressure. We need to be measuring blood glucose levels, screening for type 2 diabetes, and looking at their lipids. So it's about having an idea of what baseline status is, and then being able to keep comparing it at regular intervals. What we want to try and do is try and look at the modifiable risk factors for diabetes and cardiovascular disease. So can we help with smoking cessation? Can we help with lifestyle issues, maybe medication for high blood pressure, high blood fats? Can we look at ways of increasing physical activity, addressing poor diet? So it's not maybe giving a lecture about healthy food. It actually might be supporting people with severe mental illness on how to shop, how to cook, for example, and addressing sleep disturbances. So these sorts of lifestyle programs have actually found to be incredibly effective, but often these are the programs that are often poorly funded or not continually funded when budgetary constraints come into play. It's also important that the mental health team look at utilising the diabetes team as well. And this is one of our biggest problems, that things are often done in silos. And so people with pre-existing severe mental illness often don't fit into other health services very well, outpatient services in hospitals. So this becomes problematic in terms of failure to attend or not being given the time or the understanding from other clinicians on how best to help with behavioural change. And of course, diabetes services aren't known to be embedded into mental health services. So this is, probably one of our biggest problems, is our systems don't really support people on atypical antipsychotics at high risk of developing type 2 diabetes or those that have developed type 2 diabetes. The Canadian Diabetes Society, again, has looked at the interplay between pre-existing mental health conditions and then the problems then in develop what the outcomes could be. And diabetes is listed as one of the most important risk factors or outcomes for these medical conditions. And we play a lot of focus on things like suicide risk, but maybe not so much on diabetes. So there aren't really clear strategies on what to do for people who have yet to develop type 2 diabetes. They may in fact have pre-diabetes, they could have been checked. Their blood glucose levels are higher than normal, but not yet what we would deem or diagnose as type 2 diabetes. So what could we do in terms of medicines? Well, we could add metformin. So metformin can be written off-label. It's actually incredibly cheap off-label. So you don't need to have type 2 diabetes to be on metformin, and it will have some benefit in reducing insulin resistance. So it will improve the way insulin works, and the slow release will have some impact in stopping the liver from releasing excessive amounts of glucose into the blood when it's not required. It can reduce weight, but it may not for people on atypical antipsychotics, but it may help more with weight maintenance rather than weight loss. But we need to be aware that in women, it can make them more fertile. So again, there needs to be a discussion around contraception as well. So there has been some studies done overseas to look at other diabetes medicines to add after lifestyle interventions for people who have yet to develop type 2 diabetes. And this is through the weekly GLP-1 injections, which are not insulin at all. So in Australia, we have semaglutide and dulaglutide, which are weekly GLP-1 injections. So what we found in a study that was released in 2017 on a weekly GLP-1 that we don't normally use in Australia, is that for people on lorazepam or clozapine, they actually could lose, on average, more than 5 kilograms of weight, and that actually reduced their risk of developing type 2 diabetes significantly, to the point that many actually then had normal glucose tolerance. So they'd gone from pre-diabetes to normal blood glucose levels. For those people known to have type 2 diabetes and severe mental illness, how would we manage their diabetes medicines? Well, we'd of course always have them on metformin, which is what we would commonly do. We could add another oral agent called DPP-4 inhibitors. They can lower blood glucose levels a little bit, but they're not that good in terms of reducing appetite or weight loss. So instead, what we would prefer is that weekly GLP-1. So that is then supported by the PBS. So if you've got someone on with a healthcare card, for example, they're going to be able to get the weekly GLP-1 at the PBS price. And that would be our preferred option after metformin. We would not use the sulfonylurea in someone with pre-existing type 2 diabetes on atypical antipsychotics, because the sulfonylurea is actually going to make them hungrier than what they already are. So again, it's not the agent of choice. So is to say, after metformin, if you want to start an agent that is not going to cause hypos, there are agents that you could look at doing. Yes, that DPP4 inhibitor in tablet, but there are other agents that we could use as well. And it's really looking at then the weekly GLP-1 in terms of high risk of cardiovascular disease or pre-existing cardiovascular disease. And for a number of people on atypical antipsychotics, they already have cardiovascular disease, or they're at a very, very high risk of cardiovascular disease because of what those agents do to lipids and blood pressure. Or they might actually also have other issues like heart failure or reduced renal function. And that would be using another oral agent that would actually reduce further progression of heart failure and chronic kidney disease. So when we look at the weekly GLP-1 injection, it is not insulin at all. It will not cause hypos when you have it with metformin, and it will give us quite substantial weight loss for a number of people. Other people, it will actually just mean that they'll stop gaining weight. And if they've gained, often a substantial amount of weight on atypical antipsychotics, and you hear of people gaining 20 and 30 kilograms, they'll at least stop gaining weight on that. And it's a once a week injection. So there's quite a low complexity in terms of starting this medicine. So how does all of this work? So when you eat carbohydrates, and carbohydrates are broken down into glucose, that glucose then leaves the stomach, enters the intestine, and there are cells that line the intestine that release this hormone GLP-1 into the blood system. And imagine it like the Roadrunner on speed. It's going to race straight to the pancreas and straight to the beta cells. And it says to the beta cells, release insulin into the blood now, turn that insulin tap on, because just behind me is a whole lot of glucose sitting in the intestine, ready to go into the blood supply. And you need to move that glucose into cells, particularly muscle cells. But it turns off a tap in the pancreas. So when we haven't eaten for hours and hours, particularly overnight, in order to ensure that we have a certain amount of glucose in our blood all the time for brain function, alpha cells in the pancreas release glucagon, and that in turn allows the liver to release stored glucose. So the last thing we need is stored glucose entering the blood system when fresh glucose is about to come through from the intestines. So it turns off that tap. Then it actually says to the stomach, stop emptying, whatever's in there, just stop emptying. And that then activates to the brain to say to the brain, you're no longer hungry, stop eating. And this all happens in a number of minutes. However, when you have type 2 diabetes, that is actually really delayed. So what happens is people with type 2 diabetes, they don't release insulin very well in response to eating carbs. They often don't turn off the glucagon response. So the liver is actually releasing glucose, even though they don't need it, even though fresh glucose is coming through. Their stomach empties fast, it doesn't slow down, they don't stop that gastric emptying, and they never turn off the appetite. So people treated with atypical antipsychotics are hungry all the time, and then if they develop type 2 diabetes, they're even more hungry on top of that. So this is where these weekly GLP-1 injections are just so important in trying to reverse that. So the dulaglutide, the semaglutide are the two that are currently available in Australia. What we know is that when we give these injections, we do get a substantial reduction that's maintained in the HbA1c, the 3-month blood glucose level, but we also get a substantial reduction in weight that people can maintain. And that's really important. What these injections will do is that they will really affect appetite. And so gastric emptying is substantially slowed down. People can not eat as much during meals. They are not hungry between meals. So maybe in terms of a lifestyle, their lifestyle may not be that great. They still might be eating unhealthy food, but they'll just not be able to eat as much. So they will eat less. They will start to lose weight. That has benefits in terms of things like lipids, blood pressure, fatty liver. It will substantially reduce their risk of a cardiac event or an additional cardiac event if they've had it. The other thing with these weekly injections is it could be utilised in terms of home nursing services. If someone is unable or unwilling to administer themselves with these weekly injections, carers can often provide this type of administration, or a number of depot clinics are utilising this as well. With the Trulicity or the dulaglutide version, it actually doesn't require the person to even insert the needle themselves. The device does that all themselves. So again, if there is a needle phobia around that, this device is really quite helpful. So it's something that we've found substantially important because not only does it improve diabetes control, it really does reduce cardiac event risk, and that's really the most important thing that we're trying to do. For people with known type 1 diabetes who have mental illness, again, one of our greatest issues could be self-emitting insulin, because someone with type 1 diabetes stops taking insulin, they go very quickly into DKA, diabetic ketoacidosis, or insulin might be misused as well. So we always have that risk of under or overdosing in terms of insulin use. Normally people with requiring insulin have 4 to 5 injections a day. Some might be on a pump. However, a lot of people with pre-existing mental illness may not be in the position of having private health insurance, and so they're unlikely to be using an insulin pump, for example. So again, if there are issues around adherence and having 4 or 5 injections of insulin a day, instead we may be looking at having a pre-mix insulin like Ryzodec or Novomix. It's not going to be ideal, but it's better than omitting several injections a day. So this webinar is looking at pre-existing mental health conditions and then diabetes. You would be aware that people who develop diabetes can ultimately later develop mental health conditions. So this is not what this webinar is focusing on today. If you were wanting more information around the GLP-1 injections, we have other webinars that focus on that and the additional benefits of that. So I recommend that you look at those webinars as well. Thank you so much for joining us today.